After opening the airway, check your patient's ventilation. If the patient still isn't breathing well, you should immediately assist or control the respiration. Mouth-to-mouth ventilation is one option. Here, we'll discuss the use of a bag valve mask apparatus. There are different types of bag valve mask devices. Here, you'll see ventilation with either the typical self-filling resuscitation bag, like an ambu bag, or with a free flow or plenum-style anesthesia machine circuit demonstrated. To ventilate a child, first choose the correct size mask. The proper size covers the space between the bridge of the nose and the crease of the chin. The wrong size prevents a good seal. Place the apex of the mask over the bridge of the nose, not its tip, and press firmly. Lower the mask over the cheeks and allow the edges to grab the bunched cheek tissue. The bulk of the cheek now fills the gaps between the mask and the patient. Make sure the lower lip is inside the mask. Note the final position of the fingers. The thumb and forefinger press the mask against the face and form a C shape. The remaining fingers grip the bony mandible and pull upward, forming an E. The mask seal is created by the opposing force of the thumb and index fingers pushing down against the force of the last three fingers pulling up on the bony mandible. Don't press on the soft tissue under the chin because this can increase airway obstruction by pushing soft tissue in the epiglottis back over the laryngeal outlet. Placing a small folded towel under an infant's shoulders sometimes helps to open the airway. Pillows are seldom needed and may worsen airway obstruction in a baby or toddler. Let's look at mask ventilating another child. This child is 6. You can see how the fingers at the top of the mask make a C shape. The fingers under the chin gripping the bone make the E shape. The view from the opposite side and the view looking towards the head show how the face is being pulled into the mask against the counter pressure of the thumb and index finger holding the mask against the face. Even when the provider switches hands to perform other tasks, the mask seal can still be maintained using the same grip with the other hand. Protect the eyes. It's easy for the mask to push open the eyelids, exposing the eyes to corneal abrasion. Consider taping them closed if the patient is unconscious. To ventilate, squeeze the bag. The chest should rise with each breath. Both children and adults have a tidal volume of about 8 milliliters per kilogram of body weight. A 10-kilogram child has an 80 milliliter tidal volume. Watch the chest rise as you squeeze the bag to gauge the volume of breath you're delivering and the resistance to ventilation. Pediatric inflation pressures are lower. Use smaller breaths to avoid pneumothorax and stomach distension. Stomach distension hinders lung expansion, promoting hypoxemia and possibly vomiting. If stomach distension becomes significant, you may need to pass a small flexible suction catheter into the stomach to decompress it.
Okay, not much back there. Notice I'm not really...
A normal resting tidal volume is about 8 milliliters per kilogram of lean body weight, regardless of age. However, this can mean a difference in tidal volume from 40 milliliters for a 5-kilogram baby, 160 milliliters for a 20-kilogram toddler, or 800 milliliters for a 100-kilogram man. In the face of such small tidal volumes and their higher oxygen consumption, the infant or toddler must breathe more rapidly than the adult to compensate. For an infant, 30 to 60. For a toddler, 24 to 40. For an adult, 12 to 16 breaths per minute. Pay attention to the resistance you feel as the lungs inflate. Obstruction makes squeezing the bag more difficult, whereas a leak in the ventilation system makes squeezing the bag very easy. In both these cases, however, the chest won't rise. When in doubt, have a helper listen to the chest as you ventilate. You should hear breath sounds. Although there are some medical conditions where breath sounds are hard to hear, the absence of breath sounds almost always means inadequate ventilation. If an end-tidal CO2 device monitors the patient, you should see evidence of exhaled CO2. Always use the least force required to effectively inflate the lungs. It takes a lot less force to give a 50 milliliter breath as opposed to a 900 milliliter breath. Too large a tidal volume risks pneumothorax, especially with children. Relax the left hand slightly for the few seconds it takes for the bag to refill. Gripping the mask too tightly can cause your hand to cramp. If your fingers spasm, you'll lose fine motor control and have difficulty maintaining a seal. If you have a good mask seal, little or no air will escape around the mask. You can tolerate some leak as long as you can ventilate the patient. If you don't have a good seal, then you must get a better fit. Typically, the leak will be on the side with the bag opposite the hand holding the mask. To improve fit, rotate the ventilation bag attachment to change the point of maximum pressure. Reposition your hands. If you have an assistant, ask her to push the cheek up against the outside of the mask at the leak sites. Hypoxemia rapidly causes bradycardia in children. When a child develops bradycardia, treat for hypoxia first. Recheck your hand position and oxygen source. Increase the depth and rate of ventilation. The heart rate usually returns to normal quickly, although atropine may also be needed.